Okay, our next presentation explores the critical link between equity and technology, named Better for Everyone, Why EDI Makes Better AI. And to present that, we are joined by a leader in the field of responsible innovation, Dr. Lovedeep Gondara. He's the head of AI research and development at Vanguard and an adjunct professor at UBC, with a PhD in computer science from SFU and over 90 publications. Lovedeep works at the intersection of generative AI and fairness. His expertise spans both healthcare and finance, focusing on building AI systems that are not only high-performing, but also trustworthy and equitable in production. Dr. Gondara.
Thank you for the kind introduction. Before I start, I just want to apologize. I'm fighting with a horrible chest infection from last couple of months. So in case I launch into a coughing fit, so I have a hot drink here. Thanks for having me here. As the title for the talk says, Better for Everyone, Why EDI Makes Better AI. It's not an aspirational title. It is a claim that I'm going to back by evidence, and I'm going to make a case for it in next 15, 20 minutes. So in my present role, I lead AI research and development at Vanguard, where my team works on deep learning, NLP, responsible AI systems. Before I joined Vanguard, I spent over a decade working at Provincial Health, where in my latest role before I left, I was leading research in development and deployment of AI systems at BC Cancer. So the talk itself borrows heavily from a collaborative paper that we published, but I have angled it more towards what this conference is focused on, that is putting patients first. Before we get to the frameworks and the evidence, I want to ground it in real patient impact. These are not hypothetical scenarios. The first number, over 200 million Americans were affected by a single biased algorithm. This was the Optum care management system. For people working in healthcare and analytics, like these are a few of the famous cases. This Optum algorithm, it was used to identify patients who would benefit from high-risk care management options. And to make that decision, this algorithm used healthcare cost as a proxy. It sounds pretty reasonable on face value, but the problem was that Black patients in the US, they face systematic barriers to accessing healthcare. And hence, they incur lower costs at equivalent level of disease burden. So that doesn't mean that they are healthier. That just means they have barriers to accessing proper health care. So using that proxy variable, this algorithm consistently rated Black people as less sick than equally ill white people. It was not designed to be biased, like there wasn't a person sitting there designing this algorithm on purpose to make it racially biased. It was the choice of that proxy variable which looked very innocent at the face value, and it was well-intentioned, but it ended up being a carrier for structural inequality. The second number is showing us a threefold disparity in the use of pulse oximeters. So the pulse oximeters, which are used virtually in every clinical setting, a few studies came out that showing that some specific brands of them were overestimating oxygen saturation in patients with darker skin pigmentation. So what that led to was, that patients with darker skin pigmentation had nearly 3 times the rate of occult hypoxemia. And So that resulted in when the patients had dangerously low oxygen levels, the device simply did not detect it. The device said that the oxygen levels were okay. So that is at the bedside what these devices were doing. And now imagine this, we use these devices to collect all the data in the ER systems in the hospitals, and then we use this data to train our models. Now, if we are collecting faulty data and we train a machine learning or an AI system, it is going to have that bias now baked in. And the researchers building that system might not even know it. The third example is from the sepsis model, EPIC sepsis model. It missed 67% of sepsis cases when it was deployed. And it was deployed across hundreds of US hospitals. When researchers did an external validation on it, it achieved an AUC of 0.63, whereas when Epic was marketing it, they were marketing it with AUC of 0.76 to 0.83. So with this sepsis model, 2 out of 3 sepsis cases went undetected. This is not an accuracy problem. It was a fatal problem for the patients where sepsis was missed because of the system. The bottom line and the framing for everything that follows, putting patients first requires putting fairness first. And this is not just a slogan, it is the central thesis for this talk. Let me introduce a concept that I'm going to use to anchor the rest of the discussion. And I want to do it with this little story. In 1934, the US National Library, they introduced audiobooks. At the time when audiobooks were introduced, they were created exclusively for visually impaired users, a small, constrained population with a very specific accessibility need. Fast forward to 2024, audiobooks are $8.1 billion global market, which is projected to grow to about $81 billion by 2034. And the vast majority of users of audiobooks today, they have no visual impairment whatsoever. They're just commuters, gym goers, multitaskers, just listening to audiobooks when they have time. So that shows us that a technology designed for margins can become mainstream. Similarly, for text-to-speech, that's the same story. Only about 5% of the population has a clinical need to use text-to-speech, but about 26% of college students use text-to-speech voluntarily. And the market is projected to grow from 3.6 billion to about 14.6 billion by 2033. So the pattern, we can give it a name, the inclusive innovation dividend. When we design for the most constrained use case, when we design for the margins, we are forced to solve harder problems than designing it for the bulk. And those solutions often turn out to be valuable for everyone. This constraint, it's not a limitation, it's a catalyst for better design, for better implementation, to make systems more robust. And here's the patient parallel. And this is the core of what I want you to take away from this talk, if it's only one thing. The AI tools built for patients who are hardest to serve, patients in rural settings, patients from underrepresented communities, patients in resource-constrained environments. These tools, if we design them to work in these scenarios, they need to be more robust than a tool that we design for a general scenario. They must handle greater variation in the data quality, in imaging conditions, in comorbidity profiles. And as a result, they produce systems that are more generalizable, more reliable, and ultimately safer for every patient, including patients in well-resourced urban settings. And this is not a charitable argument, this is an engineering argument. Designing for the margins is how you build AI that actually works in the real world for everyone. Now, if that is True, if inclusive design produces better systems, why is it not the default? The answer is persistent and damaging assumption that pervades in the industry. It is the perceived trade-off between equity and performance. You might hear it in budget meetings, in industry, even in healthcare, that we cannot afford to do fairness testing on top of everything else that we are doing. You hear it in engineering discussions. If we add fairness constraints, if we train our model with this little fairness loss, we are losing on accuracy. You hear it in regulatory strategy, that let's get approvals first, let's build the system, and then we'll address equity, then we'll make the system fair. Fairness is usually framed as a tax on performance, something that costs you accuracy, speed, or resources. On the left side of this slide is what it looks like in practice. Traditional AI development starts with narrow, demographically homogeneous training populations on the majority demographic. And that's the data that's the easiest to collect. Fairness is treated as a compliance checkbox instead of something that we need to think about at the start. And when we discover bias post-deployment, it is patched reactively, if it is discovered at all. And over time, it accumulates technical debt and patient outcomes degrade in ways that might not be immediately visible, but that might show up later. On the right is the alternative, patient-centered inclusive design. You design for the diverse patient population from the start. You treat equity not as a burden, but as a pathway to clinical excellence. You build fairness into the system from day one rather than working it as a patchwork. The key message in the next few slides is going to be that this trade-off that people think about it is false. The evidence from past few years has increasingly shown that the fairness and performance, they are not in tension. In many cases, they are mutually reinforcing. Let me give you a roadmap for the evidence that I'm going to present. We identify 4 creation mechanisms through which inclusive design can generate returns. Talking in business language. Pathway 1 is expanded access. So how do we use AI to reach patients who currently have no access to diagnostics and care management tools that they need? Pathway 2, patient safety. How do we prevent AI systems from causing harm, from misdiagnosis, biased triage, or automated coverage denials, as you have seen south of the border? Pathway 3, clinical accuracy. This is the most counterintuitive claim. The fairness constraints actually improve model performance. Pathway 4, trust and adoption. Even the best AI tools are useless if clinicians will not use them and if patients do not trust them. Fairness is the foundation for that trust, both for clinicians and for patients. I'm going to quickly walk you through each of them. Let's start with a scale of that unmet need. About a quarter of world's population lacks adequate access to primary health services. AI has enormous potential to close that gap, particularly for diagnostic tasks that currently require specialist expertise. But it can only do so if it is designed for the populations that need it most. Here is what happens when it is not. A lot of melanoma detection algorithms that came out in past few years, they were trained predominantly from images of lighter skin people. The result, it was higher misdiagnosis for patients with darker skin tones. And this is not an edge case. It was a systematic failure that rendered the whole systems useless, including much of sub-Saharan Africa, South Asia, and significant minority population in Western countries. A tool that only works for some patients is not a tool that you can deploy equitably. Now contrast that with another system, IDXDR, and this was the system that showed inclusive innovation in action. IDX-DR was designed specifically for primary care settings where there was no ophthalmologist available. The constraint was there was no specialist in the loop. It forced the developers of the algorithm to build a system that was fully autonomous, that could handle the imaging variability that you get in the primary care clinical setting, rather than a specialty center that could deliver reliable results without expert interpretation. And it became the first FDA-approved autonomous AI diagnostic tool. So the constraint did not limit the product at the end. It produced a fundamentally better, more deployable product. The cost effectiveness numbers are compelling for IDX-DR. Diabetic retinopathy screening in rural India achieved about $1,320 per quality adjusted life year, which is well within the standard cost effectiveness thresholds. Google's partnership for IDX-DR is targeting about 6 million AI-supported retinal screenings in India and in Thailand. And this is what an ideal inclusive design looks like. And expanding the access is necessary, but it is not sufficient. Even when we have an inclusive AI tool, patients still need to trust it. And right now, many of them do not, and rightfully so. Nearly 2/3 of US adults report low trust that health systems that use AI are using them responsibly. Over half have low trust that AI tools will not cause harm to them. And these are not niche concerns. This is a majority of the population expressing doubt. Most important finding is that odds ratio of 0.66. That is telling us that patients who have personally experienced discrimination in healthcare before, they are significantly less likely to trust AI in similar settings. If the healthcare system has failed you before, why would you trust an automated algorithm in the same healthcare setting? Think about this from patient's perspective. An AI tool that works well on average but produces less accurate results for your demographic group, it's not a tool that works for you, and that's not a tool that you're going to trust. So we need to do better. We need to design systems that have that in mind. So for everyone in this room, whether you're building AI, deploying it, regulating it, advocating it for the patients, that trust, it must be earned through demonstrated fairness. That means transparent subgroup reporting, showing performance broken down by race, ethnicity, sex, age, different socioeconomic indicators, inclusive validation, testing in the clinical environments where the tool actually will be used, just not some internal validation. This is not something that is nice to have. This is something that is must have. Now let me frame the inclusive design from the other direction. What happens when you don't invest in it? The top left number, $451 billion, that's the estimated annual burden of racial and ethnic disparities in the US, roughly 2% of their GDP. This is the economic cost of unequal health outcomes, and it is borne disproportionately by the patients whose communities can least afford it. When we deploy biased AI into the system, we do not just fail to solve the problem, we risk compounding it, making it worse. And the top right number provides an important context. 16 to 18%, that is the incremental cost of comprehensive bias testing and inclusive validation, as estimated in a research study. In dollar terms, for a typical FDA track AI product, this goes maybe in hundreds of thousands, not in millions, not in billions. And in the table, the Optum Care algorithm that we talked about, it wasn't a malicious design choice. It was a proxy variable problem. Epic sepsis model was deployed at scale that harmed many patients. There was a problem where it was marketed in a way that didn't show the reality. And right now, Cigna PXDX and the United Health NH Predict systems, they are subject of an active litigation where patients are alleging that they're denied coverage or they're prematurely discharged from the care based on decisions made by an algorithm. And no one knows why or how that algorithm is making these decisions. So what does it take? Fairness constraints, they do not degrade model performance. In many documented cases, they improve it, such as in that Optum study that we have talked about before. Once the researchers took the findings and they fixed the algorithm, the referral rate for black patients went from 17.7% to 46.5%. That is near tripling of appropriate care for patients who really needed it. And this improvement did not come at the expense of other patient groups either. The performance was maintained for everyone across all the demographics in the system. Just fixing the bias, it made the model better for everybody. So why does that happen? So there are four main mechanisms, and they apply broadly, not just in one case. First is fewer missed diagnoses. Second is corrected measurement bias. Third is reduced shortcut learning. And fourth is better calibration. The EPIC sepsis model at the bottom, the AUC of 0.63 versus the vendor reported 0.76 to 0.83. And that's what happens when we skip inclusive external validation. So broadening the argument beyond just the algorithms, two other factors that are equally important: the data we train on and the people who build the systems. On the data side, the All of Us research program is perhaps the most compelling example, where inclusive data collection sequenced about 245,000 genomes, with 77% of participants coming from communities that are historically underrepresented in biomedical research. This resulted in over 275 million previously unreported genetic variants, including 3.9 million with predicted coding consequences. And this is the biology that is completely invisible in the Eurocentric data sets that usually dominate genomic research. On the team side, diverse teams produce better AI systems, and the evidence extends beyond healthcare. McKinsey's latest analyses showed that companies in the top quartile for workforce diversity are 39% more likely to financially outperform their peers. But the mechanisms matter more than this one statistic. Plural teams, teams with diverse backgrounds, perspectives, lived experiences, are more likely to anticipate subgroup failure needs. They ask different questions when we are designing the system. They stress test across different heterogeneous clinical workflows. They catch the edge cases that other teams might miss. And those edge cases in healthcare can endanger patients. And then there's a tail end dimension that should concern everybody. With what's going on in the US, the international students' arrival has declined 19% in August 2025. 61% of US computer science PhD recipients earned their bachelor's outside. So that is the main tail end pipeline. So the organizations need to create inclusive environments that lowers the barriers to entry and make people feel that they belong so they can contribute to the societies after they graduate. They feel welcome instead of feeling like they're a stranger. So the evidence that I've presented so far makes the scientific case, but on the regulatory front, it is also shifting, and it is shifting fast. In 2024, the US Department of Health and Human Services, they updated their rules where the non-discrimination provisions of the Affordable Care Act. And they explicitly address patient care decision support tools. Covered entities are hospitals, health systems, insurers. They now all must identify and address potential discriminatory impacts of algorithms used in patient care. In 2025, FDA issued draft guidance emphasizing transparency and bias assessment in AI-enabled medical devices. The EU AI Act that came into force in 2024 mandates representative data sets and bias mitigation measures for AI systems. And at the state level in the US, there are different laws. Similarly, in Canada, we have provincial level and federal level. And I want to anticipate the question that probably most of us are thinking. It sounds very compelling, but what is the dollar cost? How much it costs extra for us to do this fairness and inclusive testing? Let me ground this in a specific case, going back to the diabetic retinopathy, using 2D fundus imaging. The baseline cost of developing an FDA-approved AI product in this space is approximately $3.4 million. The inclusive innovation increment, the additional investment required for comprehensive bias testing, diverse validation, and fairness infrastructure is about $770,000, which is about 18% of the total cost. If a company does that, the returns on top of it are projected to be 25 to 40%. Reaching patients in rural, underserved, and global settings, which otherwise these tools won't be able to reach. And where does that 770,000 goes? It goes into fairness-aware algorithms, multi-site validation, fairness infrastructure, data, and validation. The economic side for this is very clear. An 18% increment in development cost produces from 25 to 40% expansion in the patient population that you can serve. So this is not a cost center, it is an investment with a measurable gain. And let me close the argument by presenting what I see as a strategic divergence that is already underway. On the left are the organizations that put patients first. These organizations invest in inclusive design now, not later. Their AI tools are validated across diverse, real-world clinical settings. They earn trust through transparency, publishing subgroup analysis, conducting independent audits, engaging with the communities their tools serve. They benefit from network effects. More diverse patient populations generate richer data, which trains better models, which earn more trust, and which drives better adoption for the tools. And they have the first mover advantage. On the right side is the status quo. Organizations that treat fairness as a future concern, a compliance checkbox, someone else's problem, or something that they can patch on later. Their patients from underrepresented groups continue to receive inferior algorithmic care. Their models fail when they encounter edge cases, when a demographic shift happens, which inevitably does in real-world settings, as all of us do know that. Clinicians and patients, their trust erodes in the system as failures start mounting up and the failures become public. Remediation cost at that point, it escalates after preventable harm. And regulatory penalties, they increase as oversight tightens. The critical insight is that this divergence compounds. It's not a one-time gap that can be closed later with a catch-up investment. The organizations investing in inclusive AI are now accumulating advantages in data, in trust, in regulatory precedent, and in clinical relationships that become progressively hard to compete with the organizations that are not doing that. And I want to leave you with this one sentence, that AI designed for every patient works better for every patient. This is not an aspiration. This is what the evidence shows. From the papers that we looked at and to the IDXDR approval, to the all of us genomic discoveries, that pattern is consistent. Inclusive design produces superior systems. And with that, I want to thank you all for taking the time and coming here, and I'm happy to take any questions that you might have.
Thank you, Dr. Gondara, for the timely topic. I think it's fair to say all of us are dealing with how to explore the benefits of AI in our organizations fairly and responsibly. So thanks for the presentation. Open it up for any questions. Yes, please.
Thank you very much for the insightful presentation. I learned quite a lot from what you said. I just have a question about a catch-22 sort of ingrained in this work as well. Mm-hmm. A lot of what we talked about today relies on evidence that is being looked at retrospectively. So once things have been deployed at scale, and so we're seeing large numbers, and that's where we can pick up these disparities. And I think also in your last slide, you mentioned collecting more data can help us to identify these problems and then work towards them. What are your thoughts on more proactive ways in which we can bake equity considerations before things get deployed at scale? Because unfortunately, to realize these consequences later down the line is quite costly and quite detrimental.
Yeah, so definitely it needs to be considered before deployment and well before deployment, right? And that's what I was trying to get at, that when we are gathering data to train the model, like if you're training an AI model, you need some sort of data to train it, right? So when you're gathering that training data, put some more effort into gathering the data. Don't just go with what's available, because what's available is most likely going to be the majority demographic that's easier to collect on, right? That's the easiest way to get a lot of data, and that's what a lot of companies do. They go to the easiest source that is available. So that's where I was saying that if we put a little bit extra effort at that stage when we are gathering the data, not only gather the data on the majority demographic, make sure that you capture the tail ends of that data distribution. That's where the minorities are, right? It might be demographic minorities, socioeconomic status, and everything along those lines. So collect data keeping in mind where you are going to deploy the tool that you are training, not with the mind that what's the easier way to get more data. Like and it pays off. Like if you spend some more time gathering good data, you build a good system, it is going to pay off once you deploy it.
I'm between you and lunch, so time for one last question.
Thank you. This was fascinating. I've heard from patients that they want to be involved in the design phase and that would go a long way to improving trust. What's your, are there examples of how the field is engaging patients at that level, or what's the appetite or openness to having patients involved, like right from the very beginning?
Yeah, that's a great way to design any system. If you're designing a system for an end user, in this case, the end user is the patient, having that end user involved in the design from inception, that's ideally how you want to design any system, right? And I would say not everyone is doing it. I've seen a few researchers doing that, where they engage end users, might be patients, might be clinicians, if you're developing a system for clinicians, trying to find the points of friction early on. Because often what happens is we design these systems in silo, and at the end of the day, once we design and deploy them, the person who you are intending these systems to serve, the person's like, I didn't even ask for it. Why are you giving me this? What is this, right? So having those people, whether it's clinicians, patients involved from the start, that is the recipe to create the best and the best usable systems in the long run. Yeah.
Thank you, Dr. Gondara, and thanks for coming all the way from Toronto when you're not feeling at your best. So
thank you, appreciate it.
If you have any further questions to Dr. Gondara, Dr. Grail, or Claire, you can catch up with them over lunch or during the break. So thank you.